All right, everyone. It looks like we are live. I can see people entering in, so thank you all. We will go ahead and kick things off since we are at the top of the hour. We do have a lot to cover and a lot of folks joining us today. So thank you all so much for being here and sharing your time with us as we discuss the hot topic of GLP-1 drugs and all that comes along with them, the good, the bad, and the ugly. Now, before we get started, we do here at TrueScripts like to begin every presentation with our mission statement. This isn't necessarily because we just think it's overly clever or anything, but simply because it is so critical to who we are and why we do what we do. And that mission is very simple. It is to build lasting relationships. We do this by providing prescription benefit management expertise at a personal and customized level to ensure optimum value at the lowest possible cost. Basically, to be the best partner to you all, we must earn your trust. And we know that that can only be done through honest action and open communication. So thank you all again for allowing us this opportunity to share our expertise and communicate with you today. Before we dive in, I just want to cover a few housekeeping items to make sure we're all in the flow of things. So just to let you know, the chat is disabled. Mics are muted, cameras are off. If you have a question, you will see a Q&A section up at the top. So please feel free to pose any questions you have at any point in time in that Q&A. I cannot promise that we will get to all of them during today's session, but our team will absolutely be sure to follow up with you afterwards. And for those who are unable to join us today, the session will be recorded and shared with you all. So let's get down to it. The DL or down low on GLP-1s. So as you're all aware, last year's breakout success of the GLP-1 drugs as a means of weight loss, there have been, there's just an overwhelming appetite for knowledge, no pun intended there, in terms of coverage options, patient outcomes, safety, all of the above. There are still many unknowns and ongoing developments surrounding the use of these drugs in weight loss management. And we're just really thankful for this opportunity to share with you all what we do know and how we can offer our support to you and your members as we navigate these waters together. So joining me today to tackle this topic and answer all the hard stuff are Miss Lisa Gish and Miss Stacy Bain from the TrueScripts team. Lisa is our Director of Product and Market Strategy. She is a registered nurse by background with a Master's of Healthcare Administration, and she is also a certified pharmacy benefit specialist. Just an all-around good gal and a powerhouse of intelligence. Now, Stacey is our National Director of Business Development and Innovation, and she is also a PharmD by background. So she just brings a very unique edge to our team and being able to support partners from a business development perspective and a clinical perspective. Both of these ladies are an absolute wealth of knowledge, and I'm so excited for y'all to hear from them today. So just to kick things off and give an overview, lay the foundation for today's conversation. Stacey, if you don't mind, I'd love for you to begin by just giving a brief overview of what GLP-1 medications are, how they work, the benefits they provide for both type 2 diabetes and obesity.
Sure. Thanks, Allie. So thought we'd start with just a little bit of base information. No pharmacology classes here, but just wanted to make sure that everyone was on the same page and kind of understood how these medications work, what they stand for, kind of where they got their start, and then we'll touch upon the benefits for both type 2 diabetes and weight loss. So the GLP-1 medications actually stands for glucagon-like peptide 1. This is actually a naturally occurring hormone that exists within our system today. And what happens is when we eat, our body starts releasing this hormone. And it does a couple different things for us. So it increases our insulin production. It's going to lower glucagon production, which actually then impacts how our blood sugars, managing those blood sugar levels. It slows our digestion and actually potentially shows that it's growth within our pancreatic cells. So we have more cells to produce insulin within our own own bodies. So back in the 1970s, early 80s is when this actual hormone was actually originally discovered. And they realized at that point that it controlled blood sugar and appetite. In the 1990s, then they started to do research and realized that this hormone played a key component in managing type 2 diabetes and also potentially with regulating blood sugar and hunger. In the early 2000s, they developed the first GLP-1 medications, looking to make sure that these could last longer within our system. So this GLP-1 hormone that's naturally occurring is released and our body utilizes it up very quickly. So it doesn't stay around in our system for very long. So what they were doing when they were studying these were looking for medications that lasted much longer. So between 2005 2010 we had the first FDA approved GLP-1 medications. These were actually FDA approved for type 2 diabetes, and those were Byetta and then Victoza. And then we sit where we are today with a handful of products available, both FDA approved, indicated for both weight loss and type 2 diabetes. When we think about the benefits that are associated with these, really it comes down to managing blood sugars, especially for our type 2 diabetes. And it manages to do these. So more controlled A1C levels. We reduce the risk of potentially hypoglycemic events, which is when your blood sugar drops too low, which can be a concern as well. And then weight management. So these medications help us feel fuller longer. So we typically intake less calories, which is what leads to that reduction in overall weight. And then there's some additional benefits that we see from these as well. So cardiovascular benefits, heart attacks, strokes, improved blood pressure, improved cholesterol levels. So there's a lot of different benefits that come from these medications. But at the end of the day, they really help manage appetite, help control our blood sugars, and then just improve overall health markers.
Thanks, Stacy. Fantastic overview of the drug in general. So now, in terms of efficacy, safety, and patient adherence, how do GLP-1 medications stack up against other treatment options that are available? Are there any significant risks or side effects that are associated with the GLP-1s that should be considered, and maybe other treatment options don't have those other significant risks or side effects?
No, so great question. I think the thing to note about the GLP-1 medications is that they are very effective in managing, especially type 2 diabetes. So we know that they're very good at lowering overall blood sugar levels and controlling those A1C for our type 2 diabetics. And they also are really good at producing some weight loss when we look at this from an obesity perspective. I think the thing to consider is that they are typically very well tolerated medications. So typically the most common side effects are going to be those within the gastrointestinal area. So could cause nausea, vomiting, diarrhea. And those typically are all dose dependent. So the higher the dose, more likely to experience those sorts of GI or gastrointestinal side effects. Lower doses, we expect to see those longer. And as a patient or member is taking these medications and is on a higher dose for a longer period of time, typically we see that those side effects are going to be reduced. So very typically well tolerated. I think the thing to consider outside of the gastrointestinal, we do see that or know that these can potentially cause pancreatitis. We would want to avoid these in any members that have any sort of family history or past medical history for thyroid tumors. We know that in clinical studies that these tumors were shown to occur in rats when they studied them. So we would want to avoid it in anyone that had any sort of thyroid tumor, past medical history. And then there's some gallbladder issues as well. So it's not uncommon to see some gallstones with these products as well. So typically very well tolerated overall, and we do know that they do a great job in controlling type 2 diabetes, as well as weight loss in those individuals who are morbidly obese. And I think that's part of the conversation. When we're talking about weight loss, we're really talking about someone who is considering this from an obesity perspective, who has concomitant conditions, really someone whose BMI is greater than 30.
So you touched on this a little bit. Are there any other patient demographics or comorbidities that could affect the efficacy or safety of these medications? And or alternatively, are there patient demographics where these medications could lead to other health benefits?
Yes. So I think when we look at these medications from a GLP-1 perspective, as prescribers are looking to transition people to these products, both for type 2 diabetes and or weight loss, there are a lot of additional benefits that we know that come from these and some that show those more than others. So when we look at concomitant conditions, comorbidities, so is the member also at risk from obesity and or cardiovascular events? Those are all things that prescribers would be looking into. Could the member also benefit from, from the kidney protective or the liver protectiveness that we know that comes from these as well? So there are a lot of additional benefits that we're seeing. I think the biggest thing is that a lot of these medications have, from a weight loss perspective, have only been out in the market for a shorter period of time. So we really truly don't know at the end of the day what sort of benefits could potentially come from these outside of what has initially been identified. So we know these cardiovascular events, we know it can lower blood pressure, improve cholesterol levels. Those are really the some of those key components as to why a prescriber or why a member might be on one or another. Those are really kind of the driving factors around why one might be better for someone else than others.
And you bring up a good point about not having the full long-term picture. And I think that also applies to the economics of it. And I think that might be where some of the biggest gaps in information exist today, especially when it comes to the long-term economic considerations. But that's a very important discussion, point of discussion nonetheless. Lisa, if you are, I'd love for you to chime in and just provide some insight on the cost versus benefit analysis of including these GLP-1 medications on self-insured plans, knowing what we know today and that there are gaps in information and we don't have that full picture. But can you give some insight on that cost versus benefit analysis?
Yeah, I'd be happy to. We've seen use of these drugs for a long time. Stacy did such a good job of giving us an overview of these medications, and they've been on our health plans for a while now. And from a diabetes standpoint, we're going to continue to cover them because a lot of individuals do meet that criteria every day. So, as I've said multiple times, if these drugs were $200 a month, we probably wouldn't have the conversations that we've had around them. So, the challenge though is considerations around both sides of this equation. So, if we're covering for diabetes, how can we do the most with making them affordable, economical, making sure we're getting the return on our investment? On the other side of the coin, if we're thinking about covering them from a weight loss standpoint, do we have to cover all drugs? Are there some that make more sense than others? And then what do we do to make sure if we're taking that step that we are getting the return on this investment? So, we have to think about all of the elements in that. From an economics benefit standpoint, right now, I would venture to guess that GLP-1s as a therapeutic class of medications are within almost every plan sponsor's top 10 of drug therapeutic categories, and probably a whole lot higher than what most people might realize. And I would guess within the next 12 to 18 months, they're probably going to be in the top 5. And that has to do with a couple of things. And this all goes back to the economics. So we have more patients who are eligible to take these medications, but we have more medications coming onto the market. We have more medications that are already on the market getting additional indications for their use. So you put all of that together, and what happens is that the economic impact becomes so much greater. And so one of the things that we recommend is a good, strong prior authorization program. And that holds true across this whole class, regardless of what indications we're covering it for. We have to make sure that the use is appropriate, that it's used for FDA approved indications, and that we have standards that are in place that are recommended on a national basis. And so there are other things that we can put in place, though, like from a weight loss standpoint, we may want to make sure one of our clients may want to make sure that members are going through a clinic that they have access to, an existing program that they might offer from a wellness standpoint. So just everything that we can do to wrap around those members to try to ensure they're successful in their therapy so that they get the return on investment that they're making.
Thanks, Lisa. If we think about and consider the long-term healthcare costs that would be associated with untreated or inadequately managed diabetes and or obesity, what are your thoughts on how the cost of the GLP-1 medications stack up against those potential implications?
Well, the complications and the impact, cost impact, productivity impact, every impact you can think about from the burden of diabetes on our bodies is significant. So, I think the population of type 1 diabetics, I mean, we have another challenge with them, and that's not who we're talking about here. We're talking about type 2 diabetics and probably not as aggressive blood sugar management as anyone would like in a primary care world today. So, we measure that on a 3-month basis. It's the hemoglobin A1C, and that's exactly one of the indicators that we look at when we're considering who's a candidate for these drugs, because the research behind these drugs has shown that they are dramatically successful at managing hemoglobin A1C, which is the average blood sugar over a 3-month period. So whenever you have blood sugar that's in a good clinical control, you do allow your body to operate like it was intended to. So the micro vessels are not going to have as much impact. And that's your circulation, that's your eye retinal circulation that impacts everything to do with what's inside of our bodies that's going on as well, where we see the diabetes complications just wreak havoc. So the thought basis obviously is good investment. However, what's investment mean? So when we talk to clients and advisors, one of the things we talk about is what's the turnover at your company. Are you employing a population that it makes sense to invest in, or is this a short-term gain? And what I think we'll see is on the diabetes side, these are medications that if you qualify, you qualify. But when you're thinking about should we add a benefit for weight loss and for the weight loss indicated GLP-1 medications, that clearly has to be one of the factors you're thinking about.
Absolutely. Those are excellent points. You could be investing in a benefit that you will not be around to see that benefit of. So great considerations. Now, Lisa, since we're on the topic of economic considerations, and you all on the session today had submitted some questions here, and the hottest one is, how can we control the costs of these drugs? Next to specialty drugs, these GLP-1s are oftentimes a big number 2 hitter for plans. So knowing what we know today, Lisa, what strategies can be readily employed to manage the high cost of these GLP-1 medications while also ensuring that patients have access to the treatment care they need? So in other words, we're not just excluding the coverage of these drugs from the plan, but pulling some levers to help manage those costs when they are included.
Yeah. So first thing is a good coverage policy regarding access and prior authorization. So within prior authorization, we need to be looking at what has the patient tried before. We need to look at their lab values. We may need notes from the doctor's office to put all of that clinical picture together. So that's clearly one step, and we have to make sure that who is doing that prior authorization is looking at it with the eyes that we want them to. So again, at TrueScripts, we don't own pharmacies, so we're not approving medicines simply so that we can fill those prescriptions. And I think that's really important. So we've taken ourselves out of that dogfight completely. So we're able to remove a conflict of interest that gives us more objectivity whenever we're looking at prior authorizations and the result of those. I think that then once we cross that hurdle, then we have to look at what are the options in terms of making sure we're paying lowest net costs. So the majority of these medications are rebatable. And so when we talk about what we're paying for them, we really have to look at it in two lenses. One is what are we paying at the per claim level, and then what is coming back to the client in a rebate. And of course, rebates don't happen at the point of service. They happen a few months after that, the rebates are paid on a quarterly basis, as everyone knows. So we look at total net cost. That helps soften the blow, but it doesn't soften the blow immediately. Some of those plan sponsors may also be interested in pursuing other sourcing, international possibly. We do have some supply and demand challenges that has happened in that channel. But again, at the point of sale, you have a lower unit cost or per dose cost. So that may be something. And then we also have some unique arrangements that have emerged where we may be able to do some cost plus pricing on these medications. So, I think the answer is there's multiple levers, but what you don't want to just settle for is rubber stamp prior approval processes and then just a standard network discount, because there's more to be put into that equation to help drive that cost down.
Yep. I think it's again, just going back to having that open communication, asking the questions, digging in when an opportunity presents itself, and the TrueScripts team is always open and available to do that. I do see there's a question in the Q&A while we're on the clinical side of things. Do these drugs have an expiration date to them? She says, I'm assuming so, and therefore, how long are these drugs typically valid to use once they are prescribed?
That sounds like a Stacy question to me.
I'm going to take a stab at this. So I assume when we talk about valid to prescribe, we're not actually talking about how long they're good for, more to the point of how long would somebody maybe be on these or taking these medications based on their diagnosis. So when we think about type 2 diabetes, if someone is a type 2 diabetic, they're going to likely need to be on these medications long term. We know that they're controlling their A1C. When we get their A1C to a level that's appropriate, right, and is treating that member well, they have to basically continue on that medication to keep their A1C in check. Now, I do know that there are times where their A1C may be appropriate, but the member might be experiencing weight loss or weight loss above and beyond what might be ideal, right? So if someone is not morbidly obese and didn't have a lot of weight to lose from the beginning, might be a type 2 diabetic, needs the A1C control, there may be an opportunity or use case where members are taking this intermittently. So they take it to control their A1C, and then they would stop taking it so that they don't continue to see the weight loss experience. When we think about it from a weight loss perspective, we likely are potentially talking about the same kind of use cases. So we know that members have to take higher and larger doses to experience that weight loss, and that at some point, typically most of these members will plateau, and we will see that the member no longer experiences additional weight loss. So this is where I think it's important, one, to look at how we're approving these medications. I think we'll dive into this in an upcoming question around the prior authorizations. But on the weight loss side of things, do we need to be reviewing those prior authorizations more frequently, with more frequency? Is there an opportunity for members, once they plateau, to come off of the medication, be off of the medication for a period of time to see how they maintain their weight loss, and then potentially go back on it if weight loss, or if they start to see weight gain? I think it's important to note, especially when we're talking about weight management and obesity, is that medication is not enough alone. We can't just manage obesity through a drug. There has to be additional support for these members that are taking these medications from a weight loss perspective. So lifestyle modification type wraparound services. So whether that's diet and exercise programs in place to help support that member while the medication's able to do its job. We know it's not enough if the members are not changing their behaviors. So that's an important piece of this as well. I think to answer the question from a diabetic perspective, we typically know what that treatment period is going to look like From a weight loss perspective, we still probably don't know exactly what that looks like because we just don't have a lot of great information. But we know that there are opportunities where people are going to plateau and the member maybe no longer needs to take that medication for a period of time. So lots of things to consider. That's why we're having this discussion today. And I think staying in the loop and staying educated is most important, because I will tell you, this changes literally almost on a daily basis. There is a new article, new research that comes out, new FDA approved indications. This is literally a moving target. And so what the recommendation could be today could likely change in a month, in a year. And, we just don't really know where this is going to end up at this point. But great questions.
Thanks, Stacy. Now, Lisa touched on it a bit before, and you just alluded to it again. But is there anything else to add around the criteria that should be considered in determining eligibility for coverage of the GLP-1 medications and what we are doing? So everyone, just so you all know, Lisa and Stacy both sit on our P&T committee, our pharmacy and therapeutics, and they meet on a frequent and consistent basis just to discuss all things in the wild, wild world of big pharma, and make sure that we are consistently moving with the ebbs and flows so we can stay in front of that moving target that Stacy just discussed. So sorry, Stacy, back to the criteria that we use to determine coverage of that. Is there anything else we can add there, just to let all of these plan sponsors know what we are doing on our end to ensure the right drug at the right cost at the right time?
No, I think this is important. And when we're having this conversation, I think this is one of the key elements to making sure that members have access to medication, but we put some guardrails in place. So when we think about coverage criteria for a type 2 diabetic, obviously we want to make sure that they have a type 2 diagnosis, that we're reviewing lab results, like Lisa mentioned, so A1Cs, fasting glucose, that we're monitoring and making sure that these members truly need the medication from a type 2 diabetic perspective. When we look at it from a weight loss perspective, and again, we're talking about obesity here. We're not talking about someone who wants to lose 10 or 15 or 20 pounds from a cosmetic perspective. We're talking about members who are truly obese. Typically, that's a BMI greater than 30. And what comorbid conditions go along with that? Do they have other comorbid conditions as well as obesity that we know that they are potentially at risk at? That could be hypertension, dyslipidemia, sleep apnea. There are a lot of other conditions that go along with the obesity that I think we need to consider. The other point to note, I think here, and I touched on it briefly, was in what period of time are we looking at these prior authorizations? I think yearly for our type 2 diabetics makes sense. I don't know that yearly for someone who is being treated for obesity makes sense. I think these need to be reviewed more frequently. Maybe that's every 6 months, maybe it's quarterly, to make sure that they are still being compliant with some sort of diet and lifestyle modification program, that they are continuing to see weight loss and improvement in other areas, blood pressure, cholesterol, and that the member is continuing to progress in a manner that we would like them to progress. And again, it gives us an opportunity to review that. Maybe there's a chance where the member can go off of the medication for a period of time, and then we reassess. So I think with these medications, there's a lot of assessing and reassessing to make sure that it's valid for the member and that we're utilizing them appropriately.
Thank you, Stacy. So we covered that leg of coverage criteria, but now, Lisa, if you could add in kind of the trends that we're seeing among plans, how they are currently covering GLP-1s for diabetes management and or weight loss.
Yeah, I'd be happy to. I don't know that we've seen anything truly innovative or different so much so on the diabetes side. I think, the criteria, good standard criteria are pretty straightforward there. First and foremost, let's make sure what they have tried before. Let's validate the diagnosis. Again, validating the diagnosis just kind of weeds out the off-label use of these medications. So that's pretty important. So I'll jump to the weight loss side because I think that's where we get more questions, and there's more challenges and concerns. So on that side of the equation, we have seen companies that have an affiliation as a client of a clinic service, an on-site or near-site clinic, invoke the services of that entity, sometimes to help with managing these patients. So, you have to be a patient of the clinic. Sometimes clinics may have weight loss programs that they promote, or they may simply be able to provide ongoing counseling. We have seen other clients and other plan sponsors that we talk to use some of the national programs that are out there that are cropping up really fast right now because of these medications. So, having a good wraparound program, I think, is essential. Whatever that is, I think needs to fit the personality of the company. So, whatever best fits that culture. It could be an online program. It may be someone local. There's so many options, but I do think that's essential because, again, we're, looking at making this significant investment in making sure that we're driving towards goals. And typically the goals here aren't necessarily only weight loss, as we mentioned, but there are other, clinical needs that the patient probably has with regards to other indicators, their blood pressure, their blood cholesterol, things like that. So we have also seen, I just recently, someone who had a requirement that there, at every quarterly check-in, there was an amount of weight loss that occurred. So, whether that was in pounds, I believe it was percentage, but nonetheless, it was not huge. It was incremental and it was reasonable. And I think that's important to consider. But what are the other parameters? And I think that's where we have the true ability to be very creative in applying prior authorization criteria on the weight loss side. Again, on the diabetes side, there's some things you can do, but it's all kind of going to come back to one kind of set of standards. On the weight loss side is incorporating what other plan benefits might be available. And also, we can do step therapy there too. There are other weight loss medications. Has someone tried those? How did that go if they did? Just really exploring that. But other services that might really benefit the member in the long run.
Now, on the other side of services or kind of wellness programs, are there any other alternative prescription treatment options for employees when insurance does not cover these medications for weight loss?
I mean, there are certainly older weight loss medications or medications that have been around for a long time. Phentermine, everyone may remember, there was a craze in the 90s called Fen-Phen, two products that both begin with the same set of letters. But there are certainly other medications that have come. Contrave is another one that we see. So, the impact of those has not been as dramatic. And I think that is, and they also haven't came without side effects. So, as patients take therapies, that we're all kind of tuned in for the easy button or the easy fix type approach. So, we've seen a lot of people go on those medicines, come off those medicines, but it probably is worthy to make sure that there is something that has happened before just going on a GLP-1. We think that's prudent in the criteria. We certainly have it embedded into our criteria.
Thank you, Lisa and Stacy, for covering all of that there, guys. I know we just covered a lot in a little bit of time. So again, any questions you have, reach out now, later. We're always here and willing to help. Now, the next part of this ecosystem that I want to move on to, and a big area of importance to plan sponsors and members and us alike, the patient outcomes and the quality of life that are associated with any prescription treatment plan or wellness plan in general. There's a lot of concern and speculation here, so we'd love to just dive into some of that and clear up anything we can today, or at least just have an open discussion on it. So Stacy, and this ties in, there's a question in the chat. Sorry, let me pull that back up. The GLP-1 medications, we've talked a little bit how they can impact a patient's quality of life, their long-term and short-term health outcomes. And a question here was, are there any medical concerns around using the medication, or is it more based on the high cost of treatment versus ROI? So we know there are concerns on both ends. Stacy, if you would mind to touch on that a bit and just discuss a little bit how these GLP-1 medications can impact a patient's quality of life. Gosh, I'm sorry, guys.
No, it's good to know these medications are, we're talking about them because they do work, right? We've seen some impactful outcomes, not only for your type 2 diabetics, but from a weight loss perspective as well. And I think especially when we're talking about obesity, the outcomes, if they're utilized appropriately and the member is supported, can really be impactful. So when we think about all of the positive benefits that can come out of someone losing a significant portion of their body weight, there's so many additional benefits. And not only are these health benefits, I mean, we talked about the cardiovascular and all of those additional health benefits. I think the thing that we haven't yet addressed is the benefits of just self-confidence, of your knees and joints don't ache, there's less pain. So our members showing up to work in a better headspace, more confident, are they better, more productive members at work, right? So there are so many additional benefits that come from losing a significant amount of weight. I think, again, we have to do this very cautiously and carefully. Obviously, there's a large expense that goes along with managing these, but there are so many additional benefits out above and beyond the health benefits that we're seeing in clinical studies. So again, the cardiovascular, the stroke and heart attack. There's a lot of different things that we're seeing. I will tell you, there's a lot of additional benefits that are currently being studied, where we may see that these medications are used for a whole host of things that fall outside of type 2 diabetes and obesity. So obviously, as we treat more and more patients, we have more and more information as to the impacts, and we may continue to see these medications utilized for other indications as well, which could be interesting to watch and kind of keep an eye on. One thing to note, though, and I know we haven't really talked about this, is when we think about kind of safety and efficacy, I think it's important to note how members are accessing these medications. So these medications kind of through normal mainstream channels are okay, but we know that there's opportunities to get these through compounded pharmacies. There have been some counterfeit product that has actually made it into kind of mainstream distribution, and there are many different online sources in which you could access this medication potentially at a lower cost. I would caution anyone into utilizing or purchasing these products through some of these other means. While they may look like they are less costly, unfortunately, we don't always have insight into how they're being produced or the safety and efficacy around them. So the compounded product is not the exact same product that is commercially available. And I think that's important for people to be aware of as well. So the expectation and the efficacy and potentially outcomes for the commercially available product may look very different from that compounded product. So just want to, a little word of wisdom or a little word of caution there, that while there are some other products available, those outcomes and potential side effects could look very different depending on the product and where it's sourced.
Stacey, talking about outcomes and side effects, let's talk a little bit about if and when a patient were to stop taking these medications. At that point in time, have they created a bigger risk for themselves in the plan with potentially higher medical or even other RX costs? And this ties into one of the questions we had in the chat. She asked, why are we told, or that public opinion is that once started, a person cannot stop the treatment or they will gain the weight back? Is it possible to stop treatment once optimal weight is reached and maintain it? So the safety side and the weight management side, what insight can you provide once a patient were to stop the RX treatment plan?
I mean, realistically, if we're speaking it to this from an obesity perspective, if a member has stopped these medications and has not made any changes to their lifestyles or their habits, we would expect that that the weight is going to come back, plus probably more. That's just typically what we see when we look at or review any weight loss products, right? Whether that is medication or even some of the other alternatives to weight loss options out there. If members don't buy into a lifestyle change and modification and they would stop taking these medications, then yes, we would expect the weight to come back, and typically comes back at a percentage more than where they started, right? So this is where, when we talk about medication alone, while it seems like the easy and quick fix and we all want to push the easy button, in this instance, we know that members will not be successful if there is not additional support around them when taking this medication. Lisa talked through some of those options, whether it's, what that lifestyle or modification is, but they need additional support. They need someone holding them accountable to making better choices, moving more. So we do expect, that these, from a diabetic perspective, members need to basically take it for the duration of their life to maintain their disease and control their blood sugars, hemoglobin A1Cs, all of that. When we think about it from an obesity perspective, if members aren't being supported and they stop the medication, then we would expect a typical outcome in that they would gain additional weight. So that's where we talk about some of those treatment options, and maybe we treat intermittently to manage through some of that. But again, it comes down to the additional support that they have in addition to being treated with a medication.
And I think support and education are so important on all of this. Whether your plan has chosen to cover weight loss drugs or not, again, the support and education. We have a gal on our team who had sent a picture in the group chat not too long ago and stapled up on a telephone pole like a wanted sign. It said, "We buy Wegovy, Zep." I mean, it had all the drugs listed out there, and so I can only imagine the black market rabbit hole that whoever posted that sign is going down. But in pursuit of these drugs and weight loss, we want everyone to remain safe and healthy. So again, whether you're covering these or not, it's just providing the support and education so that they can pursue their, the means of weight loss in a safe manner. So thank you, Lisa and Stacy, for covering all of that. And of course, we know that treatment of diabetes and or weight loss, the impact that it can have on workplace productivity, absenteeism, it can have significant impact there. So it's just something for everyone to consider. So now that we have considered all of that and we look at the implementation and monitoring of these medications, Stacey, I'd love if you could hit on some best practices that we use or that plan sponsors can use for implementing the coverage of GLP-1 medications.
Yeah, I think first and foremost, when we think about TrueScripts and how we're managing this, obviously these medications have FDA approved indications for either type 2 diabetes or weight loss. So making sure that members are accessing these medications based on their FDA approved indication is first and foremost. Having a strong prior authorization process in place, again, ensuring that members are not accessing this outside of the FDA approved indications, that members that are type 2 diabetic have access to the medication. When we think about it from a weight loss perspective, then what kind of guardrails can we put in place to make sure appropriate use? And again, I think Lisa had maybe shared this before. I think about 20% of our book of business is currently covering these. When we look at prior authorization approvals, we want to make sure that we're doing our due diligence in covering these. I believe about 50% of the PAs that we're receiving currently are actually being denied, being they're not meeting the criteria for use. As you can imagine, it's probably the volume is tremendous, but making sure that members are meeting the criteria before they have access to the medication is very important. Again, looking at step therapy, have members tried and failed alternative agents before jumping to this? So from a diabetic perspective, maybe that's metformin. From a weight loss perspective, maybe it's some of the oral medications, diet and lifestyle modifications prior to jumping to medications. And likely that diet and exercise modification or plan should be part of being able to access this medication. So active involvement in some sort of additional support is important to then be able to access the medication, I think is obviously important. Again, continuing to evaluate and monitor the overall success of the medication. We want to make sure that members are taking it appropriately and that we are seeing the outcome that we would expect based on the medication. And then I think education and support, right? So making sure that members understand when and where this would be appropriate. I think from an education perspective in general to your team members or to your employees, it's important that they understand the implement I can't say that word right now. That they understand the role of the medication within the organization. So the costs that are included in this, right? So obviously the member has a cost, but the organization, the plan has a large cost as well. I think members a lot of times don't understand the impacts of that cost to the overall health plan, to the organization. Obviously, being self-funded, that's incredibly important. And I think the more that you can share with and educate your employees on the true cost of these programs and potential ROI. So does the benefit outweigh the risk per se, right? So do the benefits outweigh the cost to treat? I think that's very important for members to understand, especially if you have a traditional copay structure where the member is not feeling as much of the cost. They don't always know kind of what is on the backside of that. So I think education goes along, really does go a long way, in addition to putting some guardrails in place with your PBM to make sure that the use is appropriate and that we've not just opened some sort of Pandora's box to allow everyone access to these medications.
That is an excellent point, Stacy. You guys as plan sponsors, y'all work so hard to provide excellent benefit plans to your team members. And you know, it's a wonderful thing when they can get a drug at a $0 copay, but it's also very important for them to know ain't nothing really free. So, just providing that education and they can see what y'all are doing on the back end and how that does it impacts the plan, which impacts them. They are the ones putting money into the plan. So just having that conversation and providing that education is huge. Now, Stacey, you also touched on monitoring and evaluating the effectiveness of these drugs. Lisa G, I would love if you could touch for a minute on what TrueScripts is doing to monitor and evaluate the effectiveness and patient outcomes of the GLP-1 medications.
Yeah. So again, this circles back to what we do from a prior authorization standpoint. So on the diabetes side, it's a much longer term process. So again, once we verify on the front end that the use is appropriate, that the medical standards are met, clinical criteria are met, that it kind of plugs and chugs on its own. On the weight loss side, it's a much shorter duration of time to where we're checking in again, and I'll just throw out there as well that we would modify those criteria based upon any programs that our clients have in place. So if they have a desire to have a more frequent check, we can certainly do that. We're trying to bring forward standardized criteria, but that doesn't mean they can't be modified. So we want there to be a level of comfort among our clients in how these approvals are happening, and that really does go back to maybe something that is additionally happening within their organization that we can blend into our prior authorization process. So that really is those rechecks are where you validate any of those additional points. Is the patient continuing to talk to the counselor, the provider? Are they showing positive results as it's measured, if that be BMI, for example? What are those other indicators that are put in place? So those are all the things that we would do, that we currently do with our members today.
Thank you, Lisa. We have a question in the Q&A that we've discussed, but I just want to address it directly. Deb's asking, we know we have members using GLP-1s solely for weight loss. They have no diagnosis of morbid obesity or other comorbidity concerns. Please describe the recommended PA criteria to effectively manage this kind of misuse. Now, so again, I know we've discussed the criteria that we're using to ensure that the medications are being used for diabetes. So I'm not certain, Deb, if the plan does not cover weight loss medications, Lisa, could it be that the member was grandfathered in, having already taken one of these medications? Is there anything, what can we do there?
So that's certainly a possibility, and that would be true in many cases, because again, there was a point in time where these medications were new to market, and literally the clinical criteria hadn't caught up. So that's a good possibility. I would say also, though, that have to consider the fact that there might be individuals who have other comorbid issues. So, I mean, when you're looking at from a diabetes standpoint, what is their hemoglobin A1C, and that they may not necessarily have fully come to grips with the fact that they have a diabetes diagnosis. They just haven't accepted it necessarily. So, I mean, from the outset, that really is why the prior authorization program is in place, is to make sure that the off-label use is minimized, if not totally eliminated, but also realizing that there could be a combination of factors. I think grandfathering is a likely one that we haven't really given any consideration to. But again, it's one of those challenges, right? As a plan sponsor, if people are grandfathered into coverage of a medication, you can always unwind that. It's going to be disruptive, but it could be done. So that may be something that has to be looked at specifically to further evaluate.
You just said a word there, disruptive. And plan sponsors on the call choosing not to cover these medications or needing to unwind and go back in and complete some PAs to ensure that they're not being used for weight loss, it could be disruptive to the member, but it's just something for you guys to all to consider. Is upsetting the apple cart a bit worth the significant plan savings that you all could see? And also playing into the patient safety. If these drugs are maybe not being used in a way that they should be, sometimes disruption isn't as dirty of a word as it tastes like. Now, there's some timely topics on these medications as well. And we have a question in the chat. What about the lawsuits against these manufacturers for stomach lining issues? And I'm not familiar directly with that lawsuit, but Stacy or Lisa, I don't know if you guys are more familiar than I am, or just want to touch a bit again on the efficacy and safety of these medications and the implications they may have.
Yeah, I can help here. So there are lawsuits that have happened, and the claims are that the manufacturers weren't probably as upfront, maybe, in terms of what the potential side effects were. I think one of the challenges with this is a little bit buyer beware. So, did they read the medication packaging? Were they, was that discussed with their prescriber? Certainly, one of the side effects of these medications is that, you could have long-term implications, sometimes reversible, but one of them, and it's pretty severe, is when your stomach stops working. It's called gastroparesis. That's what a lot of the lawsuits have been about. It's nothing. It's horrible. When your stomach stops working, you can just imagine. That's not a good thing. So, those lawsuits are probably going to continue, as with anything else, because certain people who get on certain doses of these medications will have those complications. Here's the challenge: you can't predict who it will be. We can't predict at the beginning of treatment what dosage and which medication might lead to those complications, because we're all built differently physically. So it's one thing I think there's some awareness here when you start taking these medications for any purpose. Again, it's not just something that exists in the high dose medications for weight loss. It also exists in lower dose medications that are the same medications on the weight loss side, but at a lower dose for diabetes. So it is really, really important that you are an informed consumer when you make the decision to take these drugs, because there are pretty serious side effects. Again, most of the time, the stories are that they have been reversed, which is great, and then someone can, discontinues the therapy and they move forward. But in those instances where it's longer term or it's permanent, that is horrible, and that leads to additional cost burdens, productivity burdens, everything negative that we've talked about.
Thanks, Lisa and Stacey. Both of you have mentioned how ever evolving the world of GLP-1s is, and it's like it seems that we learn something new every day. We recently learned that Wegovy was approved for stroke. So, guys, as all of these changes and advances come down the pipeline, again, we don't have all of the answers, but TrueScripts, we are rolling with the flow. We are evolving as these changes come down the pipeline. Lisa and Stacey, as members of the P&T committee, can you all speak to how we are handling those changes and evolvements?
Sure. I think it's important to note, especially with the most recent FDA approved indications from a cardiovascular perspective, this really comes down to we would not be utilizing these medications to treat people that are at cardiovascular risk. It still comes in addition to treating someone who is morbidly obese, who then also has these sorts of concomitant conditions. So I just want to kind of throw that out there. It's not opening this up to anyone who's maybe at risk of a stroke or heart attack, things like that. So that's important to note. I think it's also important to note that when we look at the success that these had, and we hear a lot of positive outcomes, right? That they improve cardiovascular risk, things like that, that we have to sometimes dig down into the studies to understand what the true implications are of these improvements. So in this instance, specifically in the SELECT study, when we look at what's called a number needed to treat, meaning how many people have to take the medication to see this positive outcome. Specifically in this trial, looking at this, it was 67 people. So 67 members needed to be treated with the medication to see one positive outcome. So while there is a positive outcome, it might not be as large as what people are led to believe. And so for that instance, I don't know that this is going to just open up this medication, but it is, again, something that we have to consider. It's something that we have to continue to watch and make sure that we, again, from a prior authorization perspective, that we're getting to the right medication for the right member at the right time. And so does this make sense based on the member's diagnosis codes and past failed medications and concomitant conditions? Does this medication make sense? So that's where, again, to Allie's point, this is ever evolving, and you definitely want to make sure that you're working with a PBM that is, I'll say, nimble in how they're approaching this. If you're not reviewing these medications but annually, you could be opening yourself up to some risk and some exposure to cost that maybe is not always appropriate. So that's where working with, making sure that you're working with PBMs that are actively monitoring this can help protect your plan as well and your members, right? We want to make sure that they have access to the right medications.
But gosh, Wegovy approved for stroke makes a heck of a headline. So guys, as all this stuff comes out, and a lot of it is, I mean, it's attention grabbers, and it can be exciting. It can be very scary. There are a lot of unknowns, and we're truly here to just offer our support. So the next time you see a headline announcing that one of these GLP drugs is approved for a cardiovascular means or mental health or any of the above, reach out. We're happy to bounce ideas, provide support. If we don't have the answers, we will find it there. We have just a robust team of experts. We have pharmacists, clinicians, nurses, legal experts, data scientists. We are so happy to help in any way that we can, because we know this is a complex ecosystem, but we're really just here to break down the barriers. It doesn't need to be as confusing as it's made out to be. So we are so happy to be able to provide that clarity. For any questions, please reach out. You can, if you have an account manager that you work with, they'll be more than happy to connect you with us or whomever from the TrueScripts that you may need, or that general email down there at the bottom of your screen, partner with us at TrueScripts.com, will get you connected to any one of us. If there were any questions in the Q&A that we did not get addressed, we will address those offline. But in the meantime, thank you all so much again for joining us today. We hope this was helpful and provided just a better point of view on all the craziness surrounding the GLP-1s. So we hope to talk to each of you soon, and thank you all so much. We truly appreciate you and your partnership. Lisa and Stacy, thank you too as well. Bye, everyone.